The West African nation of Ghana, with a population of about 28 million, has a mental health care landscape that reveals a concentration of her 3 psychiatric hospitals in the south of the country. The premier one, Accra Psychiatric Hospital, is located in the capital, Accra. Not too far away from it is the Pantai Hospital, with the third located at Ankaful in the central region. These were all put in place way before the Mental Health Authority was established by an Act of Parliament. Led by its first chief executive, Dr. Kwesi Osei, one of its policy thrusts is to decentralize mental health care. Among other things, the UK's Department for International Development, DFID, supported the authority with funding for office accommodation and vehicles.
They have been of great help to us. They have helped us to do a lot of advocacy in terms of printing information, education and communication materials on topics like suicide, depression, etc. And even on the Act, they have helped us to sensitize people on the Act, that the Act has come to stay with us and that we need to make sure that we implement the Act. So we've done a lot with DFID funding.
Without DFID's intervention, the Mental Health Authority would have been stillborn. We have been able to establish regional mental health subcommittees, which are the representatives of the mental health board in the various regions. We have appointed regional mental health coordinators who are effectively handling and coordinating mental health issues in the regions.
Before the passage of the Mental Health Act, mental health services had been part of the country's health services, but under institutional care. Under this regime, the full complement of mental health services was not being provided.
If you look at the Act, the focus of care, mental health services, is now community-based. So there's been a shift from institutionalization or medicalization, where patients were always treated with medications, to community-focused care, where patients are seen within their own localities so that they get the kind of family or community supports that they need. The Act came to make sure that mental health services, the full complement of services for mental health care in the country, would be provided. And with the passage of the Act came the establishment of the Mental Health Authority, which is the sole authority responsible for proposing policies for mental health services to prevent mental illness in the population and to ensure the implementation of mental health policies by the Ministry of Health. So basically that was what the Act was brought in to do.
Not every part of the Act has been implemented. The Mental Health Tribunal, for instance, is not yet in place to adjudicate speedily on human rights issues of clients.
I've gone to research on the side effects of the medication they gave us. And I said I'm not taking it again because it is given, when you take it, they say when you stop taking the medicine, it becomes worse than it is. And I said I'm not taking it again. They're forcing it down the throat. I want a second opinion of a doctor and they don't want me to go. It's not fair. They're not being fair to us. They treat us like we are not Ghanaians, but we are in Ghana. We have freedom and rights. They're infringing on our rights.
This person can fall on the tribunal, and the tribunal will be forced or is mandated to meet within 24 to 48 hours to resolve the issue. If they meet, they may realize that the admission is right and therefore will keep the person admitted, or the admission is wrong and therefore will mandate the hospital to release the person.
One of the major concerns of the MHA is the continuous abuse of the human rights of the mentally ill.
What we are doing is that we have engaged a lot of these traditional healers or prayer camps where these people find themselves, or even in our hospitals. When they are being sent to the hospitals, most of the time they are restricted. Yes, we sanction restrictions so that they don't cause harm to persons around them or to property, but we have a more humane way of doing that, and we are trying to move away from the chaining. If you look at the prayer camps, most people, when they are sent there, are chained. So when it comes to human rights, we'll say that there's still a lot to be done, and I think the authority is on top of the issue, and currently, as I speak to you, we have come up with some guidelines. We've engaged stakeholders who will help us to be able to implement these guidelines to ensure that people who are mentally ill specifically are not changed and are provided the same sort of services that persons with other physical conditions will enjoy when they visit some of these facilities.
To enforce this, the authority has been mandated to set up visiting committees.
These are committees that are set up in the various regions that will go around and make sure that people who are mentally ill are treated in a humane manner that is free from harm or anything that will cause a risk or danger to them.
Guidelines regarding human rights abuses meted out to the mentally ill have already been finalized. The next stage is its dissemination to stakeholders.
When we are sure that the dissemination has gone well, there will be a date where training in all our institutions will be banned. If you do not abide by it, the law will deal with you.
The authority is quite a distance away from meeting its human resource needs.
18 psychiatrists working in a country of about 28 million population. That means it's not good enough. For a country that is currently low middle income country, we expect to have about 100 psychiatrists. So what we have is woefully inadequate.
The case of the clinical psychologist is even worse.
Clinical psychologists we have in the public health sector just about 25. That certainly is not good. At least we should have about 100.
Not all is gloomy on the human resource front. An area of strength in Ghana as far as mental health care delivery goes is the number of psychiatric nurses.
For now, we can talk about 4,000 psychiatric nurses. That's all over the country. In the mental health sector itself, that is talking about the 3 psychiatric hospitals, that may be about 2,000, and the others are working in other areas. Generally, that's not bad.
To roll out quality mental health care to a greater extent requires the timely release of budgeted funds from government. Year in, year out, this has been disappointing.
By the end of the year, then you would have had just about maybe only 20% of our budgetary requirements given to us. That makes it not good enough. In fact, my 20% is probably even an overestimation.
If you are mentally ill, there's the issue of absenteeism, or as some people also say, presenteeism. You could be in the office, but you are depressed and you are unproductive. So you are sitting behind your desk, but by a close of day, you might not have achieved much. So we know that if we do not fund our mental health services properly, we are causing a lot of harm. There will be a reduction in our GDP. About 7% of GDP reduction is attributed to persons who suffer from mental illness in this country.
Last year, for example, we didn't get anything at all out of the allocated budget that was meant for Pantan Hospital. Usually when you go to say it, what government will tell you is that, but we paid your salaries. Yes, our salaries were paid. But what about operations?
Little wonder, therefore, the unacceptable state of infrastructure in the mental health care sector. A visit to the premier facility, the Accra Psychiatric Hospital, bears ample testimony. This is an example of how a dormitory for clients should not look like.
You can see the ceiling, everything is almost ripping off. There was a wire that is coming down. It is a patient that is trying to bring it down. And this is a live wire. So imagine this person is successful to bring it down. What can happen? Almost all the patients can be electrocuted.
The washrooms and places of convenience are a crying shame to the nation. The Mental Health Authority insists that it is not a hopeless situation. It can be turned around, pointing to one example set by the National Investment Bank, which funded the transformation of one ward as part of its corporate social responsibility. Given the funds, this is what the authority can do. The refreshing look of the VIP ward also lends credence to this hope of the authority. The same story can be told with the VVIP ward at the Pantai Hospital, where each client is entitled to a room. Contrast it to another ward in the same hospital, and one is lost for words in describing it. On another sad note, The only electroconvulsive therapy machine at the Accra Psychiatric Hospital has broken down for over 3 years, rendering the ward redundant and, more seriously, unable to save the lives of those who need the critical service it offers. The country's premier psychiatric hospital has no mortuary. Since it has been unable to build one, the new refrigerators are of no use. To make matters worse, they've been left at the mercy of the weather for years. These challenges notwithstanding, the Mental Health Authority has been implementing its policy of bringing care as close to the people as possible.
For us to appreciate the medical model of mental health care, then there is a need to integrate. So just as somebody can go to a general health care and get treatment for his malaria or pneumonia, in the same way, you go to that same place, you get your treatment for mental health problem. So that becomes the essence of integration.
Currently, even though the Mental Health Authority is in charge of the 3 psychiatric hospitals, it is collaborating with the Ghana Health Service, which has a presence in all 10 regions, to integrate mental health care into the general health care system.
At all levels, talking about the community level, sub-district level, where we have our health centers, our polyclinics, and then the district levels where we have district hospitals, as far up as the regional level. And we are doing this by asking them to see patients within their own communities. So for example, if you are not, or your family feel you need some form of services relating to mental health, they should be able to walk into a general hospital and then report. We have trained staff, community psychiatric nurses, clinical psychiatric officers who are at the level of physician assistants. So basically they are like assistant doctors who have been trained. They have extra training in mental health services to see some of these cases. It is only when they have been taken care of up to the regional level and they need expert or specialized services that we recommend that they are transferred or referred to the 3 national psychiatric hospitals.
When there was the need for sensitization, because people needed to know what the Mental Health Authority was all about, what was being done, and then also to get other stakeholders involved. We were part of that stakeholder sensitization. I know that it covered a lot of people, the police, the health workers, the teachers, other people. We were part of that. So in that sense, you find that at the regional level, it is well integrated. In the same way, when you get to the district and also to the sub-district level, it is run as part of healthcare delivery because we have health staff who are mental health staff, but they are part of us as Ghana Health Service. But we don't have any separate HR management for mental health and then for Ghana Health Service. So they are part of it. And at the district level, they also work with our district health team. So I can say that at all levels of management, they are part of the structure.
Community mental health care delivery is at the heart of the integration concept. Activities undertaken include promotional and preventive services.
We educate the populace for them to remain mentally healthy, those who are mentally healthy, things to do to remain mentally healthy, those who are about to develop mental illness, the early signs and symptoms. So we educate the general populace on mental health, how to remain healthy and how to prevent mental illness, and how to identify mental illness when it starts. In our various communities, there are packets of signs and symptoms of mental illness in our various homes that we don't know. Most of us don't know. So the core objective of community care is to educate the populace.
OPD clinical services are also offered under community health care delivery. Patients who visit the facilities are assessed and managed.
As part of the management, you have to visit the client at least 4 times in his or her home during the period of management, because we know that mental illness, causes of mental illness is biopsychosocial. So if it is biological or your physical being, there are changes in your body that can cause mental illness. Your relationship with significant others can cause mental illness, and your psychology, your being, also can cause mental illness. So that is how it is managed.
They visit the clients at home to help them identify the trigger factors to their condition and how best to manage them. Relatives are also educated to look out for certain signs and symptoms, as well as how to cope with their loved ones with mental health issues.
Those who beat their spouse, is it normal to beat your spouse? If you are angry, how do you manage your anger? Do you have to end up beating your spouse? Those people, they all need care. They don't have mental illness, but they are not mentally well too. So how should they go back to mental health or be managed? So all those things, we educate the populace on it. Some people in our various communities, they declare that they are quarrelsome. For me, I fight. No, it's not normal to just be a fighter. You have to know your limit, how to manage yourself.
A visit to the Bunahafu Regional Hospital in Sunyani reveals that integration is indeed happening at the regional level. The government of Ghana funded the psychiatric wings of this and other regional hospitals. At the Wa Regional Hospital, the regional mental health coordinator says the future is bright as far as integration goes.
The foundations have been laid for us to see the effect or the benefits of integrating mental health into the general healthcare system. As you may be aware, with the formation of the Mental Health Authority, hitherto we only had the Ghana Health Service. And so with the Mental Health Authority being formed, there is that integration between Ghana Health Service and Mental Health Authority. Now, what we are seeking to do is to complement the efforts as far as healthcare service delivery is concerned by making sure that the mental health component, which has been overlooked for so many years, is brought into the limelight. Now that would have to trickle down from the national level to regional level, district and sub-district level, even to the communities. And so with time, we are looking forward to a country where people can walk into any facility and have access to mental health care.
With funding from the Department of International Development, DFID of the UK, offices have been built for regional mental health coordinators. The Volta Regional Mental Health Coordinator describes the integration process, among others, as the silent revolution taking place in the mental health sector in Ghana.
Community mental health care has also benefited from the silent revolution of mental health care in Ghana. And through the support of DFID, we are able to establish the Regional Mental Health Subcommittee, which serves as an advisory body to the mental health coordinator. And by this, we are able to integrate mental health care with other stakeholders and agencies.
These coordinators have been put there to coordinate and help implement mental health activities or policies which are passed at the national level. And they collaborate with these same agencies who provide health services, the Ghana Health Service, CHAG. And as far as engaging prayer camp healers or traditional and faith-based healers, we realize that with the socialization and the exposure we have on this part of the world, people attribute all signs, all forms of reasons to persons who suffer with mental illness. And we believe that, even though they are an informal part of the sector, it is good to collaborate with them. And we have done this through the use of the coordinators as well as our community psychiatric nurses. So currently, as I speak to you, every district has at least one community psychiatric nurse who is supposed to liaise with the public health facilities as well as the traditional and faith-based healers to make sure that persons who go to them for mental health services are given or get the right form of treatment or care that is required.
Integration is most prominent at the Pantine Hospital, which rolled out the concept at its inception.
Besides the psychiatry that tends to be our mainstay, we also have the general health care, and we have an OPD that takes care of all the general health challenges. We have an ART center, which is antiretroviral therapy center, where people living with HIV/AIDS come to seek help, get their medication, get screening, get counseling. Then we also have a reproduction and child health unit that takes care of women with pregnancy-related issues. And then we have a maternity where they can actually come in and deliver their babies.
Like all the other mental health care facilities, the challenges are hydra-headed.
Infrastructure, you realize that everything is running down. The buildings, and for the buildings, almost all of them, the roofs are leaking. Then the road network, the environment, the labor that we need to pay a lot of them from our internally generated fund. And it's such a huge strain on us.
Medication is at the heart of care for clients.
At times, almost like a week or 2 or even a month, some of them are not getting the medication because we are not getting them being supplied to us. And even the ones being supplied to, the potency is also of an issue. At times, you get to give medication to a patient that you hope within 1 week or 2, there can be some kind of recovery in that patient, but you're not seeing it because of the potency of the medication, and they're not also getting it as well.
By the end of the year, you'd have had probably just about 10 to 20% of our medicine needs. The rest of the time, we have to get the medicines out of pocket payment by patients, or some philanthropies, benevolent organizations, NGOs become and donate some medicines to us.
Mental health is not covered under the National Health Insurance Authority, and that means that access to medicine for the people who need it becomes a challenge. And because the supply is also not so regular, we find that the hospital, that's the psychiatric hospital, and the other people who need to have the medicines would have a challenge with that.
Successfully extending mental health services across the country deepened the problem of unavailability of medicines. The MHA is finding ways of resolving it whilst they wait for government to procure them.
What we did was to collaborate with the largest agency, which is the Ghana Health Service, to, as part of the integration, procure psychotropic medicines on behalf of our clients and just put a little markup, and if I say little, very little markup, just to revolve the fund or maintain the capital for procuring the drugs, but not necessarily to make profits to run their facilities, because at the end of the day, we expect that government will come up with some funding mechanism to support us, especially for the psychotropic medicines. We believe for the other logistics, they can collaborate with other programs like HIV, maternal and child health, so that when it comes to home visits, outreaches, etc., mental health can ride on the back of some of these programs and then have it delivered to the people at their doorstep.
Experts are warning of dire consequences if steps are not taken by the nation to make psychotropic medicines available for the treatment of the mentally ill.
With the advocacy of Mental Health Authority and all the other players, CHAG, Basic Needs, we have sort of created a demand for care. We have made noise about it, people have gotten to know, and now people want to access health services because they know where to seek help. Unfortunately, for most of these places, when they go, psychotropic medicines are not available. And I fear that if we don't address this issue immediately, it will get to a point people will not come again, because when they come, they don't get the psychotropic medicines. What will happen? They will resort to the traditional healers. They will resort to the prayer camps, and it will be, we may do the work in vain. We create the demand, but we are not able to give the supply.
In some notable respects, the psychiatric hospitals have their hands tied to their backs when cutting business deals with suppliers. This has everything to do with the lack of funding.
We more or less rely on benevolent suppliers who are prepared to lock up their money that they will supply us food items and not knowing when they will get paid. And that is quite unfortunate to make any good business. So you even lose your bargaining power over them because they supply to you at their will and at their homes and car prices and at their own prices. And that kind of make somehow the poor quality costs even more.
There are several unbecoming attitudes in everyday life that people take for granted. But for the mental health professional, these are early warning signs.
There are some children in class, they find it difficult to sit at one place. Those people, they need help. They are not naughty children. They are not difficult children. They need help. So there are some children who are bullies. There are some children who are bedwetters. All those children, those things are beginning of mental illness. So when we identify, early identification is one of the key issues here. So we identify it early, it is managed, and the child lives healthy life ever after.
The easiest way of identifying that somebody is developing mental illness is when the person is unable to cope with the normal stresses of life. That is a very critical sign. So previously, if my colleague used to do well in one area or is able to perform all the assignments I give, nothing has changed now, but the same task is unable to perform, it tells me that something is changing, and therefore I must connect the person to care. A lot of people are depressed. I think it's not only in Ghana, it's global. The burden of depression is so high. And if you see people who are unable to sleep, commonly referred to as insomnia, without any major cause, if there's no organic disease, a person is unable to sleep. People are hearing voices that they shouldn't hear. People's mood change, or their mood swings, which can be bipolar disorder. These are things that should alert us that people need to seek care. It's not only when somebody has gotten on the street, maybe naked, that is, but the early signs, people unable to cope with normal stresses of life, the insomnia, the loss of appetite, unexplained body pains, all those things are pointers.
The Mental Health Authority is also working in collaboration with service delivery agencies such as the Christian Health Association of Ghana, Basic Needs, Mental Health Association of Ghana, and quasi-government hospitals like the Police Hospital, the 37 Military Hospital, and the teaching hospitals, which provide some form of mental health care services to patients who visit their facilities.
The larger focus is to train the ordinary prescriber. If I say the ordinary prescriber, so the nurse midwife, the nurse prescriber, the physician assistants who have no training at all in mental health services. We have customized some training for them where they are taken through mental health service care or mental health training such that they are able to identify and pick up early signs of people who have symptoms of and signs of mental health illnesses. And we believe that in doing this, we reduce the fear in the community and people know where to get services when they need them, as opposed to them thinking that they're going to move from their families and come and live somewhere in the south, because we realize that all the three facilities I have mentioned at the national level, which are tertiary facilities, or I wouldn't say tertiary yet, because they don't have the full complement of staff. We are working on that, but the specialized care they need at the national level, they can't get some treatment up to the regional level, which is also seen as a tertiary level of care within our health 5-tier health system.
With the level of integration so far, is the authority picking up signs that the object of reducing stigma and freeing up space at the 3 psychiatric hospitals being realized?
I would say yes. We are trying to institutionalize our district health information management system data services for mental health. We want to incorporate it into the general healthcare delivery system. That will give us a clearer picture because it picks information from the primary care level all the way up to the top, and that tells us how many people we have seen at those places in the country. We have just launched it, and I believe they are piloting now, and work will really start in January. But as we speak, I believe the 3 psychiatric hospitals have a policy of downsizing their facilities because we realize that they are overcrowded. If you visit any of our facilities, you will realize that the persons there unfortunately undergo some form of inhumane treatment because there's overcrowding. Facilities that have been built for about 150 people have as many as 300 persons because we haven't decentralized mental health services. So in trying to do this, we realize that it's only referrals that really come to them, and that's why we think that the community aspect is also picking up.
The Mental Health Authority needs other cadres aside of the clinicians to fully implement its 3Ds strategy, that is demedicalization, deinstitutionalization, and decentralization of mental health care in Ghana.
That is the strategy. So when we want to demedicalize mental health care, it's not only the doctors, the psychiatrists, and the nurses who are needed. We need the clinical psychologists, we need the counselors, we need the social welfare. So we are working with them. Though currently we don't have mental health social workers, we are working with the traditional or the generic social workers.
The Greater Accra Regional Mental Health Care Coordinator is happy with progress made so far. He and his team have successfully ensured that mental health care is available in every district in line with the MHA's plan.
We have even gone further to ensure sub-district level there's mental health service provision, and we envisage to have a mental health service at the chief's level. And we are also to ensure the implementation of the Mental Health Act at the regional level and the district level, which we are doing. We are currently embarking on. We have also brought on board a stronger collaboration with the stakeholders, especially the traditional and faith-based healers, where we have our staff going to visit these faith-based healers to ensure that our clients who are accessing services at their facilities are enjoying the best of human rights care, and also a standardized care where their rights will not be infringed.
Several advantages accrue to clients as a result of the decentralization.
By taking the service closer to the clients in the communities, the clients will not have to travel all the way to Accra Psychiatric Hospital, Pantan, or Ankara Psychiatric Hospital to access mental health care. Thereby, they save money for transport and other inconveniences, the risk in traveling. They are able to access the care closer to them. It also makes reintegration to the community very, very easy and affordable. Either to the patient who have to come and be in the hospital, and getting them reintegrated into the community becomes a challenge.
Among challenges facing them is the lack of psychotropic medications, which situation forces clients to take what is available, not necessarily what they need.
We also have transport challenges where it is difficult to carry out monitoring and support supervision to ensure the quality of care. We have had to, our colleagues in the district have had to dip their hands into their pockets to carry out simple community-based activities because the resources are not available. Funding is our main challenge. Planned activities are unable to be carried out because we don't have adequate funding to carry out these activities. And we believe that when we have adequate funding, the quality of care at the community level will be much increased, which would result in increased community-based activities that will get patients will get care in their homes and not have to travel all the way to psychiatric hospitals. Because as we speak, lots of our patients are not getting the medication they need, and thereby they are relapsing and they have to be brought back to the psychiatric hospitals.
He says the quality of care can improve if the human resource challenge facing the region is addressed, among others.
Going forward, the region will need more community mental health personnel to augment the current numbers we have, because if you look at the population of the region and compared to the number of workers we have, it's woefully inadequate. And these are some of the challenges that, when resolved, the quality of care will be very much improved.
The Greater Accra Regional Health Directorate of the Ghana Health Service is happy with the integration process so far. Its director, Dr. Linda Van Otu, agrees that there is the need for more staff.
Within the hospitals, we would be happy if we have some of them who are attached, because you realize that some people might come to the hospital with all sorts of diseases, but there's also the need for mental health care for such people. So if we had them within, even if it was just the big hospitals, then that would be helpful. As a region, we have also established what we call the Hope Restoration Center. And this is a place where we offer psychosocial support. Initially, we started with families that have stillbirth or families that have challenges following pregnancy and childbirth. And we are working very, very closely with them. This is one of its kind. So if we had enough people, then we could have somebody even stationed there to see the people who would need their services. So for now, we work with the Mental Health Authority, but then we also work with a few clinical psychologists that we have around. And with them, with the Mental Health Authority, we have trained some people who will now act as the first line people. So they will be called first if a client goes there before we go on to give the necessary other care that we need.
Since the Mental Health Authority was established, it has been working closely with the Greater Accra Regional Directorate of the Ghana Health Service at all levels of care.
At the regional level, we work with the regional coordinator as one of our staff. His salary, for example, is on our payroll. We look at the plans that he draws for the region. We make inputs into the plans, and then they are implemented with our supervision. And during our review meetings, we do presentations on mental health to know how we are moving. Every month in the Greater Accra region, we have our regional health management team meeting, and he's part of it. He attends all these meetings, and when there's anything new to be discussed, we give an opportunity for him to do that. And that is a very good forum, because then we have managers of hospitals, managers of polyclinics, and district directors. So it makes it easy for everybody to know what is happening within the region.
Mrs. Van Otu says there's the urgent need for the relationship between the Ghana Health Service and the Mental Health Authority to be well cemented.
If we do not cement this relationship well, then even the little that the service, Ghana Health Service, was doing previously may be left undone. So there's the need for a determined way of bringing the two together. And that is why during planning, mental health plans for the region or for the national level should be part of the Ghana Health Service implementation plan. And that means that it should also go with budget, with milestones, and with an evaluation bit. So as we monitor our work in terms of Ghana Health Service, where are we reaching? Take as an example, immunization. We monitor to see where we are getting to with our immunization of children. We monitor our polio. We monitor our maternal mortality. So we should have something that is an indicator that is added to what we collect every day to monitor. That will help us as the managers to also assess the work of the regional coordinator, because then it is written. We could also sign a performance agreement with the regional coordinator because he's part of us. Then he will sign with his district coordinators, and they will sign with the other people who work under him. So policy-wise, I believe that we need to have it as a structured thing with documentation signed, and then we assess him every quarter, every month, and it should also be well integrated into our DIMS. So the DIMS, which is telling us how we are moving as a sector, should have mental health well documented. Anything that is not recorded is not done. Anything that we need to report on, we make sure that we work on it. So once it becomes part of the DIMS, then it will be documented, and we can now charge our district directors to make sure that at the district level, the coordinators also work, because we sign performance agreement with our district directors, and we could make that as part of the contract that we sign with them.
The Kpong Katamanso district of the Greater Accra region recently received a motorbike from the Mental Health Authority to facilitate their work. Before then, staff on assignment to communities had to find their way.
Those who have vehicles and can carry other colleagues when doing home visiting, they do so, or have to fund their own transportation to and from the communities where they go visiting clients.
Given that people are stigmatized, and for that matter, either they fear or they are shy to bring cases to the facility, giving them a means of transportation will do a lot of good. Again, it will also be good for educating families. Family support has been proven to be one of the important ingredients of managing mental illness, and therefore, when such people are given the means to go to the families where these mentally ill persons are and educate them, it will help improve the level of care.
Ponkatamanso is an example of the difference decentralization is making in the lives of people needing care.
Until 2014, you know the district is a new one anyway. There wasn't any active community mental health services provision in the district. Most of the clients from the district seek care or were seeking care outside the district, most especially at Bantam Hospital as well as Accra Psychiatric Hospital. But until we had the staff being posted into the district, that was what was happening. But currently, most of our clients access care within all the public health facilities in the district.
The Ponkatamanso District Director observes that there are issues with the current state of infrastructure.
You go to a consulting room that is being for community psychiatric or mental health services, and there is only one exit and entry into the facility, which is not very good, because when we have to deal with clients that are aggressive, at times it exposes both the staff and the client to risks which could be avoidable.
There is every justifiable reason for the government of Ghana to pay attention to mental health care.
In the next 5-10 years, it will be very good if the ministry will support mental health the way it supports maternal health, the way it supports child health, the way it pays attention to malaria and other non-communicable diseases. We need to pay that same attention to mental health. Given that about 41% of Ghanaians develop some form of psychological disorder, then it is important that we pay attention to it. And as Dr. Akwesi also has been saying, if 1 in 5 persons will develop mental illness in our lifetime, then everybody is at risk. It provides impetus for us to pay attention to it.
The legislative instrument, LI, that would enable the authority to be fully operational is yet to be passed.
The LI wasn't passed because we were waiting for the Minister of Finance to determine a quantum of levy to be put as part of taxation or any other means of getting funds from the general public to fund our mental health fund. But the parliamentarians were of the view that we should go ahead and get the LI fund passed and lobby with the finance minister to come to parliament to tell them how he was going to make sure that there's funding for the mental health authority. So currently we are just finalizing a few issues on it. We'll send it to the Attorney General's department, and once they have okayed it, we will send it to Parliament and get it passed.
Once we have the LI passed, we have the levy established, we have money coming into mental health authority for us to operate our services. We have the regional wings, regional hospitals having psychiatric wings. We have a regional, 1 or 2 regional psychiatric hospitals, and we have reduced the gap from 98% to probably just about 10%. We have medications We are no longer abusing the rights of the mentally ill. We are not putting them in chains. All the prayer camps would have been trained, the proprietors would have been trained to know and to respect the rights of mentally ill. I feel very much fulfilled.
In the face of all odds, the authority has determined that the only way to true decentralization is forward. But between now and when the mental health levy becomes a reality, it is calling on both local and international organizations as well as governments to help fill the yawning funding gap bedeviling mental health care in Ghana.